Good evening, sir. Hello, sir. You can make me host. Hello, sir. Am I audible?
कार्टून लगाओ हमें कार्टून लगा कार्टून कार्टून लगाओ कार्टून बच्चा देख रहे
Good evening, Dr. Brunali. Good evening, Dr. Shashi sir.
Good evening, madam. Good evening, all.
You both can just check whether your audio and video is clear before others join in.
Hello, ma'am.
Yeah, your audio, both audio are audible. You can check video also once.
Yes, ma'am.
Am I visible, ma'am?
Yes, visible. Clearly visible.
Brunali, madam, all set?
Yes, sir. I'm just starting video.
नहीं सब रेडी है ना इंट्रोडक्शन वगैरह
Dr. Brunali, you be the host and make Dr. Shashi and me also co-host. And as soon as this is done, you can just call in the speaker after 5 minutes. That is 6:45. You just call up the speaker and tell the speaker ma'am to also join. Dr. Brunali?
Yes, ma'am.
Yeah. Did you listen? Am I audible?
Ma'am, अभी आई आवाज. Sorry, I was not.
अच्छा, आई एम सेइंग कि आप होस्ट बनो. अभी आपको होस्ट बनाएंगे सर, और आप डॉक्टर शशि सर को को होस्ट बना दो. ठीक है.
ठीक
और
है.
अभी हमारे स्पीकर को एक 5 मिनट्स में आप फोन करो, जैसे आप होस्ट बनते हो वैसे. ठीक है. और उनको ज्वाइन करने को बोलो. स्पीकर को भी आपको को होस्ट बनाना रहेगा. करेक्ट.
Yes, ma'am.
And then we will just see whether screen sharing is done. We'll just keep the screen shared and we will start exactly at 7.
Sure, ma'am.
Okay.
Okay.
You want to check once whether your video is working, Dr. Brunali?
Yes, ma'am.
Thank you, sir, for making me host. So I'm the host. I'll make you host, okay? And you make me co-host.
Sure.
So you're the host now. You can make me and Dr. Shashi sir co-host, and also Riju ma'am when she joins, you can make her also co-host. And other dignitaries like Priyanka ma'am, Arpita ma'am, Archana ma'am, all those also have to be co-host only. Dr. Brunali?
She
Dr.
might
Brunali?
she might be talking to speaker.
Okay, we'll wait for a minute. Dr. Brunali, am I audible? Kindly make me and Dr. Shashi sir co-host. Kindly
it-
confirm if I'm audible.
Ma'am, you are audible.
Acha.
Hmm.
Is Dr. Brunali there?
Brunali is also there, but not responding.
Yeah. I'll call her.
Okay.
Good evening, Riju ma'am. We will just start in 5 minutes. We are waiting for participants to join. We will start exactly at 7 p.m.
Hi, good evening. Um, just a second, I'll just change my background.
Yes, you're audible, ma'am, and visible also.
Yeah.
Dr. Brunali, ma'am. Dr. Brunali, ma'am.
Hello, ma'am.
Yeah, kindly make me and Dr. Shashi, kindly make Dr. Shashi your co-host. Kindly make me also co-host and make Riju ma'am co-host so that she can start with the screen sharing.
Ma'am, actually, I joined from my mobile. So,
What about the other account through which you have joined? Because you're host in that. You'll have to make through that only.
yes, ma'am, but it's not working.
Okay. What is happening? Can you let me know?
Chrome is not responding. I think,
Can you try getting access of that account?
yes, ma'am, I'm trying, but it's not working.
Okay. What error is being shown?
Not responding, ma'am.
Just try once again, dear.
Yes, ma'am.
Yes, we can see the screen, ma'am.
Hello, good evening all.
Good evening, madam.
Hello, Dr. Brunali.
ये भिगा के रखा है।
Dr. Brunandi, are you there?
Hello.
Good evening, ma'am.
Oh.
Riju ma'am, good evening.
Good evening.
आओ ये लो कलर करेंगे.
Requesting everyone to please mute your device. It's quite disturbing. Please mute your device. To all the participants.
Good evening, everyone. Requesting everyone to stay muted. We will start soon in 5 minutes.
नाही. कोण तर दिल त्या कोणी तर दिल त्या ग
Kindly, all the delegates, keep your microphone muted. Dr. Vivek Rathod. So we have a session today, so please keep your microphone muted. We are now starting with the session. Dr. Vivek Rathod.
Dr. Vivek Rathod, please mute your mic. All participants are requested to please mute their mic.
So we will now start with the most awaited webinar. Dr. Brunali and Dr. Shashi are the coordinators. Dr. Brunali, you can start with the
Yes.
introduction.
Yes, ma'am. Sorry for the inconvenience. Good evening, everyone. Myself, Dr. Pranali Gharpure, coordinating today's session with my coordinator, Dr. Shashi Wankade, sir. I'm extremely glad to welcome you all to this much awaited webinar. This is 43rd webinar of our Blockbuster Masters webinar series organized by NIMA OBGY Central. Before starting our session, I request all the dignitaries and the participants to take blessings of Lord Dhanvantari. May Lord Dhanvantari bless us all with good health and great success. Continuing further with the webinar, I would welcome all the dignitaries and delegates for today's knowledge enhancing session on the topic cracking the code of implantation, overcoming recurrent implantation failure. To start, let us welcome all the dignitaries of NIMA OBGY Society Central Body, President Dr. Kamini Dhiman ma'am, Secretary Dr. Priyanka Nakade ma'am, Treasurer Dr. Vishnu Bhavne sir, and National Convener Dr. Rajesh Bhutane sir. Welcome you all. I would also like to welcome dignitaries of NIMA OBGY Maharashtra Society, President Dr. Suhas Herlekar sir, Secretary Dr. Manoj Gaikwad sir, Treasurer Dr. Ajay Raj Bal sir. I welcome you all. Now continuing with our 43rd webinar of the series on the topic cracking the code of implantation, overcoming recurrent implantation failure. We are honored to have here amongst us very eminent speaker, respected Dr. Riju Chimote ma'am. Dr. Riju Chimote ma'am, she is MBBS MD OBGY. She has done fellowship in reproductive medicine, diploma in cosmetic gynecology, and diploma in OBGY USG. She is She has done training in embryology and pre-implantation genetic testing from London, trained in laparoscopic advanced suturing from Mumbai. She is fertility specialist and cosmetic gynecologist and obstetrician at Vasundhara Fertility Center. She has received MS Signature International Award for Social Service in Infertile Couples and Adolescents in 2023 and received a Super Woman of the Nagpur Award for the Excellence Work in Women Healthcare Center in 2020. She is National MTP Family Planning and Basic and Advanced IVF Trainer. She is peer reviewer at British Journal of OBGY. So with due respect, I would like to request our today's guest speaker, Dr. Riju Chumatima, to deliver her talk on cracking the code of implantation, overcoming RIF. Before starting the session, my sincere request to all the dignitaries, all the participants, to kindly keep yourself muted during the session, as it is very disturbing for the speaker and all of us. Kindly put your questions in the chat box. It will be answered after the session. Now I request Riju ma'am to kindly start our session. Riju ma'am.
Thank you so much, Dr. Pranali, for the kind introduction. At the outset, I would like to thank NIMA, OBGY Central Society and Maharashtra Society for having me here. I thank all the coordinators, conveners, and Dr. Archana Pandey for having me here. Before starting, I would like to congratulate the convener for, I just went through the entire program of the master series where you have beautifully, starting from the evaluation of infertile couples to the ethics to Panchakarma, all the topics have been very beautifully covered. So I must congratulate to the person here. So starting with my topic, cracking the code of implantation. So implantation, as you know, I hope I'm audible to everybody.
Yes, ma'am, you are audible.
You are audible and screen is also clear.
Okay, sir. Okay. So implantation, as you know, it is complex. It is basically a crosstalk between the embryo, between the blastocyst and the endometrium. So here the blastocyst hatches from the zona pellucida, comes in contact with the endometrium, and then it binds to the endometrium. And during this attachment, it secretes the molecules. I request everybody to kindly mute. So,
I request all the participants to keep your mic mute. Dr. Monica, please mute yourself. Ma'am, please continue.
thank you. Yeah. So this signaling, which I was talking about from the attachment to invasion, this signaling directs epithelial withdrawal, and then the trophoblast invades the endometrium. So these are just few steps, but this signaling has so many lock and keys. So here my topic is decoding the implantation, but with so many lock and keys, I will just try, even in our clinical practice, we try so many permutations and combinations. We give multiple treatments, and I'll just try to unlock each and every key of these receptors of these endometrial receptivity one by one. So coming first to what is the definition? Just a second. I'm not able to change the slide. Can you hear me?
Yes, you are audible, ma'am.
So sorry, I'm not able to, my screen has frozen. I'll just stop sharing and share my screen again.
Okay.
Yeah. So coming to the definition of recurrent implantation failure, so till now there has not been any widely accepted definition. Earlier, what we have studied about recurrent implantation failure was transfer of 10 embryos in multiple transfers without achieving any clinical pregnancy. But here in 2024, where we are talking about single best blastocyst transfer, the definition has changed to transfer of at least 4 good quality embryos in a minimum of 3 fresh or frozen cycles in women under the age of 40 years. So overall, it is now defined as transfer of at least 3 good quality embryos in 3 fresh or frozen cycles in women under 40 years. So what is a good quality embryo? It is basically a day 3 embryo which has more than 3 cells which is symmetric with less than 10 fragmentation, or a day 5 embryo which is a blastocyst with a grade of at least more than 3 bb. Even a lot of times here, I'm talking about recurrent implantation failure, but the management of recurrent pregnancy loss and recurrent implantation failure, more or less, it is similar in a lot of sense. Even in recurrent pregnancy loss, earlier the definition was 4 or more pregnancy loss. It came down to 3. And now, according to ACOG and ESHRE, the definition has come down to 2 or more pregnancy loss, defined as recurrent pregnancy loss. So whenever a patient comes to us as a consultant with a failure or with a pregnancy loss or with an IVF failure, they always come, they undergo IVF thinking, it's going to be 100% successful, even though we explain the success rate, what are the chances. Still, there are questions like, doctor, why did my IVF fail? Could it be the age or the sperm, or is it my husband? When should not the genetic testing be done? And if you are advising this test now, why didn't you do it earlier? So, and what are the lifestyle changes which we have to undergo, and what is the possibility? What next, or what else will you do? Or, just give me a donor gamete or a donor egg and then we'll go ahead. But it is just not about the donor egg. Sometimes there's problem in the endometrium itself. So coming to the incidence, recurrent implantation failure affects 10 to 15% of couples, and amongst that 20 to 30% have immune dysregulation, the so-called unexplained. So here I'll be explaining the unexplained subfertility. So start talking about the risk factors. Risk factors of RIF starts with basic advanced maternal age, elevated BMI, smoking, alcohol consumption, stress, and male factors. Smoking, alcohol, again, it increases the reactive oxygen species, it reduces, it has a detrimental effect on the quality of oocyte, quality of the sperms. And stress, of course, it causes release of cortisol, which in turn causes pregnancy losses. So coming to the etiology, immunology. I'll be talking in detail about immunology and endometrial receptivity today. So immunology, thrombophilias, endometrial receptivity, chronic endometritis, anatomical abnormalities, male factor, and embryo factors. So like I said, the trophoblast invasion, which I was talking about earlier in implantation, the trophoblast invasion activates the maternal immune response to fetal antigens. So local immune cells at the implantation site in the endometrium, which are activated by the embryos, and it mediates the maternal fetal immune tolerance. And they involve in regulating the differentiation of residual cells and remodeling the uterine vascular and promoting epithelial attachment. So in this stage, the immune cells, including the innate cells, the T cells, the dendritic cells, and the macrophages are activated. So the T cells play a very important role in the immunity during pregnancy. These T cells are mainly of 4 types: the T helper cells, Th1, Th2, and Th17, and regulatory T or the Treg cells. So the imbalance, normally in pregnancy, there is dominance of the Th2. When there is imbalance of Th1, Th2 ratio, there will be reproductive dysfunction. So in patients of RIF, in patient of recurrent implantation failure, this Th1 to Th2 ratio increases in the peripheral blood. And the anti-inflammatory factors such as interferon gamma, the tumor necrosis factors, these mainly secreted by the Th1 cells. So these increase. So in these cases, these are mainly found out by the endometrial biopsy. So in these cases, immunotherapy or intravenous immunoglobulins will give a better results. So macrophages regulate implantation. Implantation, placentation, and the vascular remodeling at the maternal fetal surface. So macrophages located close to invade the trophoblast and spiral arteries to promote implantation during early pregnancy. The proportion of uterine macrophages again are higher in patients with chronic endometritis and adenomyosis, indicating these are the pathological factors. So I'll be talking in detail about chronic endometritis, how to diagnose, how to manage chronic endometritis. Coming to the third part, thrombophilia. So pregnancy itself is a hypercoagulable condition, and thrombophilias are believed to affect implantation by impairing the vascularization of the embryo, which disturbs the blood flow to the decidual vessels. So there is inherited thrombophilia, there is acquired thrombophilia. Inherited, we have the common forms are genetic mutation in factor V lead-in, protein C and S, prothrombin, and MTHFR. So patients with RIF with thrombophilia most commonly harbor MTHFR C677T variant, which impairs the implantation. And the most prevalent acquired thrombophilia is antiphospholipid syndrome. So it is an autoimmune hypercoagulable state which is diagnosed by the presence of antiphospholipid antibodies like anticardiolipin antibodies, lupus anticoagulant antibodies, and beta-2 glycoprotein antibodies. Again, anti-sperm antibodies. Anti-sperm antibodies, these bind to the spermatozoa and they identify them as foreign bodies. And these are mainly because of infections like STD, cervicitis, or seminal infections or varicocele. So coming to the endometrial factor, how important is endometrium in implantation? Obviously, even if we transfer a healthy embryo, not even embryo, we go to a day 5, we transfer a healthy grade 5 blastocyst, but the endometrium is not good. The endometrium is not receptive. There will not be successful implantation. So how do we evaluate the endometrium? The basic evaluation first and foremost is ultrasound. A basic ultrasound, a baseline ultrasound, a 2D, if possible, a 3D ultrasound gives a very good picture of any infertile patient. So ever since in my clinical practice, I do my own ultrasound. So I know with the clinical history, detailed clinical history, I know what to look for. But obviously for the clinicians who are referring such patients for a USG pelvis, it is just a request to not just write USG pelvis, just to write you've taken the detailed history, you want to get an ultrasound done. You know there is triple dysmenorrhea, you know the patient is giving history of any irregular menses. So write in detail to the radiologist what exactly you want to see. Like kindly comment on the uterus, kindly comment on the adnexa, kindly comment on the uterine myometrial and the ovarian cortex. So these detailed requisition will help you get a better reporting from the radiologists themselves. And always look for the just not the report but the images also. And if possible, if you can, if it is possible for you, if you can, go to your radiologist friend, see during especially in these kind of patients who have recurrent implantation or recurrent pregnancy loss. So if you see the images on your own or you do your ultrasound, you can diagnose a lot of things based on just USG and clinical history. So USG, it's non-invasive. You're talking about the endometrium. We check for the thickness, the pattern, whether it's regular or irregular, whether there's fluid inside the cavity, what is the volume, how is the blood flow to the endometrium. So this Applebaum scoring is basically when we do this scoring is basically when we do a embryo transfer. Whenever we are planning an embryo transfer, not just the endometrium, not just even a 6 millimeter endometrium can give us pregnancy if the blood flow is good, if the uterine artery Dopplers are good, if the myometrial echogenicity is relatively homogeneous. So this is the entire scoring which we do. 18 plus scoring, it's a total of 20 score, and 18 plus scoring gives a better chances of pregnancy, clinical pregnancy. Talking about endometrial receptivity. So endometrial receptivity is estimated to account for 2/3 of implantation failure. So an endometrial biopsy obtained from recurrent implantation failure on 7th day of progesterone, it revealed lot of different expression of genes related to recurrent implantation failure.
एकदा आपण काय करू, मला असं वाटतं आपण दुर्बीणतून तपासणी करून शोधायची. हा, दुर्बीणतून तपासणी केली आणि त्या गर्भपिशवी जी मागे झुकली आहे ती जर आपल्याला व्यवस्थित समोर करता आली ते करता येईल. आणि गर्भपिशवीचा आकार असा आहे की नाही ते एकदम नाही समजत आहे आपल्याला, त्याच्यामध्ये आलंय पण कदाचित असेल नसेल ते, आणि अजून काही आहे का ते पाहून घेऊ एकदा. दुर्बीणची तपासणी करणं गरजेचं आहे असं मला वाटतंय. हा, म्हणजे आता बरेच दिवस झाले की नाही, तुमची जेव्हा तयारी असेल तेव्हा मला सांगा.
Dr. Manisha Partiki madam, Dr. Manisha Partiki madam, kindly mute yourself.
Okay. So yeah, so in 25% of cases, what we see in the biopsy, what we see in the endometrial receptivity assay is there is displacement of the window of implantation. This also goes in patients where we are talking about patients who are going for ovulation studies. If we are not patients who are going for ovulation study and we are asking, patient to have a planned relation in such cases. In such cases also there is failure to achieve pregnancy if there is displacement of window of implantation. So, and prostaglandin synthesis also appears to be disturbed in cases of RIF. So coming to the most what we see, like during my residency days, I had seen a lot of cases. I think all of you have treated and seen a lot of cases of genital TB. So here in my clinical practice for the past 5 years, we've been seeing a lot of cases where we do check for TB. TB is coming out to be negative, but on ultrasound, on hysteroscopy, endometritis is coming out to be positive. There's a lot of cases of chronic endometritis, and when we do the testing, when we send the endometrial samples for CD158 and CD56, it comes out to be positive. So I'll tell you about detail about what is CD158 and 56. So endometritis is basically refers to the inflammation of the endometrium, the inner lining of the uterus, and in ultrasound, in the initial phases, in the early phase of endometritis, it is difficult to diagnose it just on a 2D ultrasound. But in the later stage, we will see a thickened or a heterogeneous endometrium. And if it's a chronic, acute on chronic phase, you might also see a fluid inside the endometrial cavity. In some cases, you will also see a hyperechoic junction of the endomyometrial junction. So this, what you see here is a hysteroscopic picture. So a lot of times hysteroscopy is done, patients already like patients who are referred for RIF or RPL, a lot of times they get all the investigations done. They say, ma'am, hysteroscopy ho gaya hai, everything is normal. But when you actually go through the videos, the images, the cavity is normal, yes, the tubes are patent, yes, but when you see the volume is fine, when you see this kind of picture is seen. In acute and chronic, like I said, you will see a lot of micro polyps as well. So this is easily diagnosed. This sometimes is missed. So if you see any such picture, it is always good to take a hysteroscopic guided biopsy. Send it for a culture, send it for a CD156 and CD58. 156, if it's positive, it is mainly, the endometritis is mainly of an infective origin where we need to start with antibiotics. CD56, again, it's because of immunological cause. So there, antibiotic plus immunological therapy needs to be given. So endometrium contains, talking about the microbiome, why endometritis? So endometrium contains 4 orders of magnitude of fewer bacteria than the vagina. Vagina harbors approximately 1010 bacteria, mainly lactobacillus, and in the endometrium during the implantation window, where it was associated with a higher successful implantation rate. Whereas non-lactobacillus dominated microbiodata such as streptococcus during the implantation window resulted in negative pregnancy outcome. So even if the patient is not complaining of any vaginal discharge or backache, or there is no symptoms of PID, it is always better whenever the patient walks to you. I think everybody does that in your clinical practice. We do a basic per speculum examination, local examination. Especially in cases of RPLs and RIF, it's better to take a vaginal swab and start with, if there is no active infection, start with at least a probiotic therapy, at least for 14 days or 21 days, depending on the symptoms of the patients, along with antibiotics. So bacterial pathogens alters endometrial microbiota, which results in chronic endometritis. It is often asymptomatic. That is why the failure to diagnose. And a lot of times it's diagnosed on either on ultrasound or on hysteroscopy. So a study on chronic endometritis had shown abundant immune cells in the endometrium and increase in 83 mature dendritic cells, CD68, macrophages, and CD8 plus T cells. So these alterations also disturb the immune status, thus increasing the synthesis of lipopolysaccharide, again an immunomodulator. Why I'm talking in detail about these immunoreceptors? Because it's important to know the reason so that we can pinpoint, our management gets better, and we can counsel the patients also in the better way. So these may also be involved in embryo implantation by affecting the immune system, the coagulation system, and endometriosis. So here I already spoke about the microbiome and the lactobacillus. So vaginal microbiodata in patients with unexplained RIF indicated that vaginal lactobacillus was decreased in RIF patients. So there are a lot of, in these days, we also get gloves. Obviously, in our day-to-day practice, these are relatively, more expensive than our day-to-day regular examination gloves, but there are also pH testing gloves where you just do a PV and it will change in color, where you know that there is change in the pH of the vagina. So coming to the anatomical abnormalities, fibroids, polyps, intrauterine adhesions, septums, Mullerian abnormalities, adenomyosis, hydrosalpinx. So fibroids, polyps, or any abnormality, if large patients usually have symptoms, sometimes they are asymptomatic. That is why it is always better to counsel the patient that if they have had a previous miscarriage, it is always better to do a detailed ultrasound, detailed baseline sonography, so just to rule out whether we have we missed any small polyp, because even a 5 millimeter small polyp inside the endometrial cavity will lead to recurrent implantation failure or pregnancy loss. Even a small fibroid per se, which is indenting the cavity, a 5 centimeter fibroid sitting on top of the fundus of the uterus will not cause any problem. We can leave it like that. We can still do our transfer. But 5 millimeter submucous myoma, which is indenting the cavity, it is always better to put in the scope, remove that, and then go ahead with the transfer. Again, with hydrosalpinx, I'll come in detail about that. So coming to, sorry, I'm so sorry. Coming to intrauterine adhesions, the most common cause of intrauterine adhesions are PID or iatrogenic. So iatrogenic, a lot of times because of DNC, because of previous history, even though we are very gentle, because DNC is a blind procedure, there because of zealous curettage, it leads to adhesion, sometimes Asherman's also. So it is always better when we have something, when we have a telescope, why not treat see the site, then do guided curettage. As ever since 2016, I've stopped doing a blind DNC. I've always done it with hysteroscopic guided, under the guidance of hysteroscopy, where we see the stalk, we cut the stalk and then gently remove it, so that unnecessarily we are not curating the rest of the endometrium. So we are not damaging that. If hysteroscopy, of course, if it is not possible, ultrasound is again a better guidance. You can always put your ultrasound probe. You know the scan, you know the location of the sac, put in the probe, you know exactly where to go, so that you are not, rotating the curate 360 degree. Yeah. So coming to endometriosis. So endometriosis again is an estrogen dependent inflammation with an incidence of up to 50% in infertile women. Earlier, as a student, we used to say endometriosis is diagnosed on laparoscopy only. But now with clinical history, like I said, if you're doing your scans, or if you know what to see, if you're doing, if you know the history, when you're doing a scan, there is, adhesion, the slip sign is negative, the ovary is not freely mobile, even in your per vaginal examination, you will get some positive clinical findings, especially in stage 3 or stage 4 endometriosis. So especially in stage 3, stage 4 endometriosis, if there is associated chocolate cyst or endometrioma, of course, the oocyte quality will decrease. The whether to operate or not, again, that depends on the level of AMH, the size of the endometrioma. That again is a whole new topic, vast topic, which I'll not go in detail. But talking about, apart from just the oocyte quality, there is also occlusion. There's a lot of adhesions, there's anatomical distortion, the occlusion of the fallopian tube, and it also affects the endometrial receptivity. So a lot of times we need to do laparoscopy just to bring back that anatomy to normal anatomy, and also it also helps in improving the symptoms of the patient. So coming to adenomyosis, whether to operate or not, a lot of times adenomyosis, the patient will not give a typical history of triple dysmenorrhea. If it is a small adenomyosis, they will not give a history of that. But again, if all the parameters are normal, they have seen a lot of cases where there is recurrent, IVF failures just because of that. Because we cannot operate or we cannot remove an adenomyosis which is too small. Yes, but as you can see in a 3D, this is a beautiful 3D picture of adenomyosis where you can see it is indenting. Even in 2D, you can see this hyperechoic areas here, which is indenting the endometrium. So anything which is indenting the endometrium, it is always better to remove. So in cases like this, we can always go in hysteroscopically, remove the indented part, because obviously we cannot remove the whole adenomyoma because there's no defined capsule. Otherwise, we'll be damaging the uterus further. If it is a small adenomyosis, do not directly go for treatment. Even though the patient will say, doctor, I have already, बहुत time हो गया है, immediately हमको treatment start करनी है. I think counseling is one of the most important factors. So it is always better to put the patient on medical management, at least 3 months of dydrogesterone for 3 months, and then do a repeat sonography, call the patient for follow-up, and then go ahead with transfer. And during transfer, too, because obviously adenomyosis also causes increased myometrial contractility. So during transfer, to prevent the expulsion of the blastocyst, what we do is start etosaban. Basically, earlier it was used for just for preterm labors, just to prevent preterm labor, which is an oxytocin receptor antagonist. Now we routinely use it since a decade. 30 minutes before the transfer, during the transfer, and after the transfer over the period of 3 hours. So hydrosalpinx, there's a lot of debate, whether to de-link or whether to clip the hydrosalpinx or whether to, just remove the tube. So a lot of times there's a debate कि ट्यूब्स तो खुले हैं, laparoscopy में the MBT, the dye test is coming out to be a positive. In HSG, the dye test is positive. Why do that? If the patient, yes, if the age of the couple is less, if the duration of marriage is not more, less than 2 years, maybe there is no history of recurrent miscarriage or recurrent implantation failure, and if the tubes are patent, then of course we can give a trial of fertility treatment with ovulation induction, with planned relation or IUI. But if the patient has a history of recurrent pregnancy loss or recurrent implantation failure, in such cases there is no point in keeping those tubes just because it's patent, because what we are seeing here is just the structural patency and not the functional patency of the tubes. So when to remove? Tubes normally cannot be seen on a basic 2D or 3D ultrasound. If the tubes are visible on your 2D ultrasound and the patient has history of implantation failure, we will not wait for 3 implantation failures in that. Even in the first cycle, when I'm planning for embryo transfer, in that if ultrasound shows hydrosalpinx, it is always better to put in a scope, go ahead again whether to clip or to de-link. Clipping, again, there's a lot of edema, and there are a lot of times there are chances that it will recanalize. So it is always better that salpingectomy is done in those cases at the hands of the expertise, of course, because again we have to take care of the supply to the ovaries as well as the uterus. So why this has to be removed, why hydrosalpinx has to remove in those cases, not so these have a negative impact on implantation, because if the tubes are patent, these fluids which are there, it can be infective, it can have an immunological effect on the endometrium, thus it may lead to implantation failure. Isthmocele, again, isthmocele is mainly seen in patients with secondary infertility. Patient will either complain of, pain on and off or irregular cycles. And a lot of times you see in a scan, there's a niche. It is also called as a niche. So this is because why there is increasing trend in, isthmocele is because of the increasing trend in cesarean sections. So this is nothing but a cesarean scar defect which we see. And when you do your ultrasound, you will see, depending on how big the defect is, if it's a small defect, if there's no symptom, we can go ahead without treatment. But if the defect is big, there is persistent fluid inside the cavity, patient is having complaints of severe dysmenorrhea or menorrhagia, we need to treat it. So that treatment can either be laparoscopy or hysteroscopically, depending on the ultrasound parameters. So it is graded based on the ultrasound measurement, depending on the surface area, which is the base and the height divided by 2. Depending on that, we grade it as grade 1, 2, and 3, which is less than 15, between 16 to 25, and more than 25. So there are different other classifications also depending on the defect in the myometrium. Severe defect, if the defect is more, if the year you can see the defect is more than 50% in the myometrium. So why that is necessary? Because just implantation or just a clinical pregnancy is not important. We need to see throughout the 9 months, patient needs to be asymptomatic, pregnancy needs to be uneventful. So in these cases, there are high likely chances of scar dehiscence. So we need to do that, repair laparoscopically, repair the isthmocele, and then go ahead with transfer and further fertility treatment. If the defect is very small, we can just do a hysteroscopic guided repair. What you see is basically a concentric rings, and which we cut with the help of cold scissors through hysteroscopy. So this is again an HSG picture which is showing a niche of the cesarean section scar, which is a small one here. So a lot of times these reports are also missed, because when any patient we send for HSG, we see a report, okay, the bilateral tubes are patent, this spillage is seen. But as a consultant, it is always better to ask for the films and then do your own interpretation. So this was the concentric rings I was talking about, which we cut with the help of cold scissors. So coming to the male factor, again, we've transferred we've done a semen analysis. A lot of times patients come with these patients of RBL and RF will come with a report, will come with a huge, bundle of reports, and they'll say, doctor, my reports are good. Why do you need to do a repeat semen analysis? My counts are good, motility is good, but then again, we have to look for DNA fragmentation index in these cases, because if the DFI is high, if the DFI is more than 25%, we need to give treatment for at least 3 months, repeat the DFI, and then go ahead with fresh stimulation and blastocyst transfer. So coming again, embryo factor, if there has been a, embryo day 3 embryo transfer of blastocyst, which is a day 5 embryo, obviously has better success rate. Even though the number of embryos will be less, the blastocyst will give a better chances of pregnancy. The other is the quality. Sometimes there's a thick thick covering, which is the thick zona. In such cases, we need to thick trophectoderm of the blastocyst. We need to do a laser assisted hatching. So here we do not, wait for another transfer failure. In the first transfer itself, if we see that the trophectoderm, if we see that it needs laser assisted hatching, in the first transfer itself, we will do a laser assisted hatching and then go ahead with the transfer. And again, so these embryo factors depends on the quality of oocytes. In PCOS, even though we get a good number of oocytes, good number of eggs, we could get a good number of embryos, but the number of blastocysts decreases, because here the number of M2s, which is a mature oocyte, is very less compared to the GVs, germinal vesicles, and the M1s which we get. Again, it depends on parental chromosomal abnormalities, the quality of the sperm, the zona, and the culture media and the endometrial thickness. So coming to the management, lot of management I've already spoken in the etiology itself. Like I said, detailed clinical history. So half the counseling and diagnosis is done with detailed clinical history and examination, local examination, PS and PV. The first time the couple walks in, this has to be done for all the patients. Even in males, a local examination is always a good option, because a lot of times we miss infection or a small lump in the testicular area. And of course, a good baseline ultrasound. So coming to investigations, I will not be talking about the basic hormonal test which we do. Like basic, we know, like when we are talking about the oocyte quality, of course, we do blood test, which is anti-Mullerian hormone, to see the quality of the oocytes. We obviously do thyroid profile, because these are the tests which patients already come to you with. The thyroid profile, your blood sugars. If the thyroid profile are normal, if the TFT is normal, even though it is always a good option to do the anti-thyroid antibodies, just to rule out any autoimmune factors as well. So talking about the endometrial causes, like I said, hysteroscopy, even if we are not seeing any problem in ultrasound, it is always good to put in an office hysteroscope to see any small intrauterine pathology or endometritis which we have missed. HSG, again, these days, for the past 4 years, I've been doing just saline sonography, which gives a very good picture with HICOC, and I've stopped doing HSG. Hormonal profile, like the endometrial defects secondary to the endocrine aberrations. the endometrial biopsy, which I was talking about, the NK cells, the T cells, and antiphospholipid antibodies and HLA karyotyping. So this was the DNA sperm DFI and the ovarian reserve test I was talking about. In karyotyping, apart from karyotyping, again, if the patient has any patient, if you're treating a patient for oligoastenospermia, even if you see a response after medical treatment, Ayurvedic treatment or allopathic treatment and antioxidants, it is always a good, practice to do a basic Y chromosome microdeletion, which is a simple blood test, because a lot of times in these patients, this could be the reason. Even though we've ruled out all the hormonal parameters, there's no, obstructive azoospermia or non-obstructive, but there could be some trait. Yeah. So treatment is individualized depending on the patient. It is multidisciplinary treatment, and various therapeutic options have been proposed, including lifestyle to immunotherapy to anticoagulant and improving the endometrial receptivity and sperm quality and PGT, that is pre-implantation genetic testing for aneuploidies. So coming to lifestyle intervention, weight loss, with smoking and alcohol, stress reduction. So this, this has to start from day one of counseling, the moment the patient walks in. But at the same time, we have to see, like, we cannot just tell the patient ki jao 5 kilo kam karke aao, and then we'll start the treatment, and then we'll plan pregnancy. So this has to go hand in hand with your medical management, with counseling. Maybe if you want to, like I said, multidisciplinary, if we need to involve a dietitian, if the BMI is towards the higher side, or or a physiotherapist, or exercises. So these exercises, a lot of patients, because they'll say that they've started gymming, at the moment we've done an embryo transfer or IVF, the patient would completely go to bed rest. So that has to be, that has to be counseled, that patient has to be motivated to take up an exercise, whether it's just yoga or meditation or walking or brisk walking or swimming, which should be continued even during fertility treatment. That includes IVF and during pregnancy as well. So IVF does not mean like this counseling has to be done. Like even if you're undergoing IUI or any treatment, you're taking hormones, does not mean you have to go on complete bed rest. The exercise which you've been doing, it has to be something which is, non-strenuous, which you can, of course, you will have to decrease the duration and the intensity of that, but then you should continue it throughout the treatment and throughout the pregnancy to get a better result. So stress reduction again, so counseling, couple counseling. Then optimal IVF endometrial procedure. Again, I will not be going in detail. Ovarian stimulation protocol, like a standard protocol, what we usually do as IVF specialist is the ANTAC protocol, antagonist protocol. But in cases where we did not get a good number of oocytes, or in cases of endometriosis, in cases of lower AMH, in cases of patients with diminished ovarian reserve, we start with a long protocol starting from day one of the previous cycle, gives a good result. Adding growth hormone to that gives a better result. Then obviously we add lot of adjuvants along with that. That includes antioxidants, that includes hormonal therapy, that includes testosterone supplement for at least 25 days, that may exceed up to at least 2 months. And of course other supplements like DHAs and all. Yeah. So, and another thing, laser assisted hatching and embryo transfer, the technique with which we are doing embryo transfer, the no touch technique, without touching the without holding the cervix, that also affects the success rate of the embryo transfer. So coming to immunotherapy again, immunotherapy, prednisolone, lot of times, even in a non-IVF cases, even in IUI or in patients who has recurrent pregnancy loss, prednisolone has a good, glucocorticoids are basically a immunomodulator, and they bind to the receptors on the they bind to the glucocorticoid receptors on the NK cells, and these decrease the number of NK cells. So in such cases, it is always a good practice to start with the prednisolone. The dose are usually not high to cause any side effect, whether the patient is going through IVF or fertility treatment. That dose varies depending on the BMI of the patient. So a BMI patient with a BMI of 30, we cannot give just a predmed of 4 milligram OD or a BD dose. There we might have to give a TDS dose. So that depends on the BMI of the patient. Again, this prednisolone, this glucocorticoid is continued till the pregnancy is positive and continued till the first trimester of pregnancy. Once the cardiac activity is noted, we gradually taper on. We should not suddenly stop the steroids. We should, if the patient is on 4 milligram or 6 milligram TDS, we have to taper it down from BD dose for 7 days to OD dose for 7 days, and then stop by the end of the first trimester. So coming to IVIG, again IVIG, it is again an immunotherapy. In cases of RPL, we obviously, like I said, there are so many locks that we need a lot of keys to treat cases of RPL. So what we do is a blanket therapy. So we do a blanket therapy, obviously, even in routine practice. We start with ecosprin, we start with low molecular heparin. The dose depends whether it's 75 or 150 heparin. If the antibodies are positive, if we've established it's a case of APLA syndrome or SLE positive, in such cases, we have to start with a 60 unit daily dose till 8 months, till 34 weeks of gestation. Same goes for ecosprin. IVIG, again, we start before embryo transfer, or in such cases, even before IUI. Even before IUI, we can start if the antibodies are positive. And this we repeat every 3 to 4 weeks during pregnancy as well. So tacrolimus, just to complete the list, tacrolimus, cyclosporin, these are not what we routinely use, but then in studies it has given that it is a plausible treatment in patients who have elevated TH1, TH2, which I spoke about. Cyclosporin, again, not routinely recommended. It is basically an immunosuppressant. Intralipids, just like IVIG, intralipids is routinely used. It is basically a fat emulsion containing glycerin, soybean oil, phospholipids, and this we usually give IV before. If we are planning for an embryo transfer, this we start give on the day of embryo transfer. So we give 20% of intralipid, we dilute that in 500 ml of NaCl, and that has to be slowly given over a period of 3 to 4 hours. Why slowly? Because of these constituents like glycerin, soybean oil, a lot of patients might have side effect, might have rash. So we have to be very careful while administering it for the first time. You have to be very slow. If the patient does not develop any side effect, then you can decrease that time from 4 hours to 3 hours in the subsequent one. So again, like we give this on the day of embryo transfer, and then we repeat it every 4 weeks till 34 weeks of pregnancy. If we are talking about intrauterine insemination, again during IUI we can give intralipids if there is an established case of immune related problems, established case of recurrent pregnancy losses. Coming to lymphocyte immunotherapy. Lymphocyte immunotherapy, again, even though ESHRE guidelines, here we always talk about guidelines, what does the study say? Still, there are a lot of studies going on about lymphocyte immunotherapy, but still it is not enough RCTs are there to establish that it has a beneficial effect. But yes, a lot of cases are going on in India as well, and a lot of studies are going on. I do not have a good number of sample size to present that today, but of course, in cases of it does not have a good effect. It does not have a positive effect in all the cases of RPL. But then again, whether to decide whether this patient who has 4 pregnancy loss or 2 IVF failures, will LIT be beneficial? So for that we do, again, there are a set of tests of CD50, CD16, CD56, CD3, TNF alpha, NK cells. We do cross matching. In such cases, if these are positive, or while we are doing hysteroscopy, or when you are taking a biopsy, you can send for a CD56. So if that is positive, or in such cases, the LIT, there are good chances that the LIT will give a positive result. So LIT, once done, what is LIT? Basically, what we do is take out the sample from the husband, take out the sample from the partner, we centrifuge that, we separate the lymphocyte, and that lymphocyte is injected intradermally on the forearm of the wife. If it is a donor sperm, or if the husband is seropositive, HIV or HBsAg positive, we can always take it from a donor or someone from a family member. So the whole point of doing this LIT, lymphocyte immunotherapy, is basically the genome which a fetus, which a blastocyst or an embryo has, is 50% from the maternal side and 50% from the paternal side. So pregnancy itself is an immunosuppressive state. Why? Because we do not want fetal rejection. So if already there are antibodies against that, which will identify that 50% of the paternal genome as a foreign body, it will reject. So here what we are doing, we are sensitizing the body that, it's not a foreign body. So we are sensitizing. Of course, we do a cross matching looking at the safety profile so that there should not be a side effect. We do a cross matching, only then we inject the lymphocyte of the husband inside to the female. And after injecting that, we wait, just like any vaccine what we give, like we wait for 3 to 4 weeks, and then we can start with fertility treatment, whether it's IUI or whether it's IVF stimulation or embryo transfers. Aspirin, again, like it helps in increased blood flow, improved uterine perfusion. It does not increase the endometrial thickness, but yes, it improves the blood flow of the endometrium. Low molecular weight heparin, it prevents, like I said, a lot of times we give it as a prophylaxis also. If antibodies are not positive, we usually start with a 60 milligram per day daily dose. If it's positive, we start with 40. If it's positive, we start with 60 milligram. So just completing the list: vaginal micronized estradiol and pentoxifylline. Again, these are mainly to improve the blood flow, improve the vascularity and the receptivity to the endometrium. So coming to the perfusions, what we do. So perfusions are mainly HCG, GCSF perfusions, the platelet-rich plasma perfusions. So why we do that is basically HCG can bind to the LH receptor and it induces the secretions of the cytokines during implantation. So what we usually do this perfusion on the day we start the progesterone. If it's an embryo transfer, day 3 transfer, 3 days before that. If it's a blastocyst transfer, 5 days before that. PBMC, again, peripheral blood mononuclear cells. We take the blood, we centrifuge, we separate the mononuclear cells, and then we infuse it inside the endometrium. And these promote embryo attachment, but still it is not, the safety profile still needs to be studied, and not many cases have been done on PBMCs. Coming to GCSF, again, these perfusions, there was a time when a lot of studies had come, a lot of studies which propose that this will improve the thickness and this will improve the vascularity and thus in turn, increase the implantation rate. But just GCSF perfusion will not have a good effect. With a larger sample study, we've seen that GCSF perfusion did not give a very good result. Platelet-rich plasma, again, platelet-rich plasma, here we are taking your blood, we are centrifuging, we are separating the platelets from that, and then we are putting it inside the uterus. So platelet PRP, these days, just perfusion, just with a IUI cannula, if you perfuse it inside the uterus, it will not have a positive effect. It is not going to activate the cytokines, it is not going to activate the growth factors or VEGF. So what gives a good result is the subendometrial injection of the platelet-rich plasma. So in these cases, especially in thin endometrium or chronic endometritis or recurrent implantation failures, what we do is we prepare the PRP on the day of hysteroscopy, and with the help of either cyst aspiration needle or with the help of ovum pickup needle, we load the platelet-rich plasma and then we inject it inside just below the endometrium, that is subendometrium. So uterus has 4 walls, the anterior, posterior, and both the lateral walls. We just inject it inside, and just 2 ml is more than sufficient. More than that, it is going to come out of the, sorry, 0.5 ml is more than sufficient. Otherwise, more than that is going to come out. I'll just quickly. So this is what you're seeing is the anterior wall injection. Again, endometrial sketching, again, during it can either be done just with IUI cannula or just a biopsy cannula and or ebicurate. So what is the pathophysiology around it is that the endometrial injury will induces the deserialization, releases these growth factors and improves the blood flow. When to do? Usually it's done in the luteal phase cycle of the previous actually treatment cycle, and only the superficial layer has to be scratched. Coming to ERA, again, it is, I was back in 2016, 2017, we've done a lot of cases, done a lot of ERAs where we start the patient on progesterone. We, on the day 6 of progesterone, P+5, we take the biopsy, we send it to check the window of implantation just to see whether it is in the receptive phase or not, and depending on that, then we plan the embryo transfer. But now, since a larger sample size has come, it has not shown a very significant effect. It is not very significant. The study did not show that very significant changes with ERA and without ERA. So we are coming to antibiotics again for PID, chronic endometritis. Like I mentioned about CD158, doxycycline, we've been giving this since age old, like since through our undergraduate days, we've been giving that doxycycline 200 milligram per day for 14 days. Second line regimen comprising of ciprofloxacin, metronidazole. There are a lot of studies which gives additional treatment of ofloxacin with metronidazole. And if when we are doing a culture, when we have done a culture, if the patient is positive for gram-negative and positive bacteria, then ciprofloxacin 1000 milligram per day for 10 days, along with amoxiclav for 8 days. And patient with mycoplasma, usually, rarely, but yeah, doxycycline and minocycline. But then again, we advise the patient that they should use contraception at that time. And once the treatment is done, in the subsequent cycle, we plan for therapy. Coming to hysteroscopy, what I was talking about hysteroscopy again, if we see a pathology on a 2D ultrasound or a 3D ultrasound, we do a hysteroscopy. There's nothing called as diagnostic hysteroscopy. We put in a scope, we treat it, we check the endometrial cavity, any pathology, any problem we see, we treat it. The video which you see here is a hysteroscopy where we are doing a bubble testing. Where I was talking about the functional patency of the tubes, this is what we check. So what we check is not the dye. When we are doing a HycoC or when we are doing SSG, we are forcefully pushing in the dye. Here we are just putting in normal saline, closing the valve, reducing the pressure of the hysteroscope, the hysteromat, and we see whether the bubbles are sucking inside the tubes or not. So these will tell whether the tubes are functional. So bubble test positive means the tubes are functionally patent. So this also helps us in taking a decision about whether to, leave the tubes as it is in cases of hydrosalpinx, or go ahead with salpingectomy or tubal clipping. Again, for cases like myomectomy, septum dissection, always and always energy source should be avoided in this, because later on in a long-term case, this will cause adhesion inside the cavity. So cold scissors, a fine micro scissors, is always better in cases of treatment of fertility enhancing endoscopies. So coming to male factor, I'll quickly finish. Male factor again, I spoke about antioxidants, I spoke about high DFI. In cases of IVF, when we are talking about the sperm, obviously we are doing ICSI in cases of oligoastrogenospermia. IMSI, of course, gives a better selection of the sperms and thus a better quality of blastocyst. Pre-implantation genetic testing, if the grading of the blastocyst is good, and we have to rule out aneuploidies. Again, mosaicism cannot be ruled out in that, but when we are talking about aneuploidies, on day 5, we just take a small biopsy, we send it for PGT, and then transfer the single best euploid blastocyst. These days, we also do NIPGT, that is non-invasive pre-implantation genetic testing, where we are just taking the drop of the culture media of the day 5 blast and then sending it for testing for any aneuploidies. So this is the summary of the entire treatment which I have just spoken about, from lifestyle management to IVIGs to aspirin to hysteroscopy to surgeries to genetic counselings to AKTs and immunotherapies. So after talking about the entire thing, when we talk about ESHRE is European Society of Human Reproduction, which we usually follow, we as fertility specialists do follow. The entire thing which I spoke about, the perfusion, the PRP, the heparin, in the intervention and in the follow-up, it is not recommended. But then in Indian population, we have seen good results with these therapies, so we still continue to go ahead with that. But yes, here also they do recommend the testing of chronic endometritis, the reassessment of endometrial thickness, and PGTA and blastocyst stage transfer. So what tomorrow holds is, already we have AI generated lot of artificial intelligence generated. We have embryoscope, where the embryoscope will see and decide which embryo, which blastocyst will give us good pregnancy, which will give us clinical pregnancy. There are a lot of algorithms which will tell that this will lead to this will give us a live birth or not. Of course, this again has is limitations, because it's very costly. It's a very costly treatment. Apart from that, there are a lot of blood tests which has come now, like gene andro, gene femina, step test, where a simple blood test and a simple endometrial biopsy with a detailed history of the previous history, the previous treatment, what medication. And of course, apart from that, you have to do karyotyping. We have to send the detail, and that AI will give you the entire plan of action as to what what kind of stimulation should be given, what pre-medication, whether this patient will get benefit from metformin or not, or whether this patient should get benefit from self oocyte, or a donor oocyte or a donor sperm will be a better option in that. So the entire algorithm comes in that. But then of course we cannot do it for all the patients, because each test costs around 20 to 25,000 per test. So like ERA, there's another like the step test which I mentioned. So ERA just told about the window of implantation, but in a step test, it tells you about the chronic endometritis, the implantation window, the dating, and how to go ahead with the treatment. So uh, this is just a basic reporting which we get from the step test and gene androgen phenomena. This again has recently been started in my clinical practice at Vanshadhara also. We have collaborated with Origin Life, and we have started with LIT and step test. And once the sample size is good enough, we'll be soon publishing that. So again, like I said, it will tell about what therapy will help, which day it should start. So these are all AI generated, and it will give a personalized plan of treatment. So to conclude, of course, to decode implantation failure, to decode or prevent recurrent pregnancy loss, we need to select the best seed by careful selection, careful history, careful diagnosis, prepare the best soil via medical management, via surgery, and plan an appropriate time of transfer or fertility treatment or IUI, and taking a different approach. Like we cannot just say ki acha IVF, IVF just has 38 or a blastocyst transfer just has 42% success rate. Let us start with Anna, we have a blastocyst, let us go ahead with the second cycle. No, we have to find out the cause, what could be the cause, add on with a therapy, and then take a different approach. So to prevent repeated failure. So we will not wait for a second or a third implantation failure and then start with all the therapies. Normally in our clinical practice, if there is already one history, we we take all these investigations depending on the history, not all, but depending on what is seen on the ultrasound, what is seen on the blood test, and accordingly treat the patient and then go ahead with the fertility treatment. So thank you so all for your patient listening. And if any questions are there, I'm free to take up. I think I've exceeded the time.
Thank you so much, ma'am, for this wonderful session. You explained everything in so detail. It's really treat for us to hear you, ma'am.
Thank
Very
you.
informative session. Thank you, ma'am. Now, for question answer session, I would like to request Dr. Shashi Wankide, sir. Hello.
First of all, Dr. Riju ma'am, thank you very much for the wonderful session.
Sure.
I must say, you have decoded all the RIF problems and given us very accurate code for the RIF treatment. Thank you very much.
Thank you, sir.
Participants, you may ask the questions if you have. Already, madam explained it very thoroughly, but you can ask any questions if you have doubt any. One question is came in the chat box from Dr. Aslesha.
Yes. So one question is there here. How should be the progesterone support in RPL? So here, when we are talking about recurrent pregnancy loss. So recurrent pregnancy loss, if that depends when the treatment, when we are what kind of treatment first of all we are doing. If we are giving the patient, if we are doing an ovulation study with follicular monitoring, post rupture, post ovulation, we start with the luteal field support. That support can be a micronized progesterone or a dydrogesterone. That dose again, usually what we give is 10 milligram TDS. And if that is total of 30 milligrams, so 10 milligram TDS of dydrogesterone, or giving a higher dose does not mean we are giving a better support. Like a lot of times we see a micronized progesterone of 400 milligram VD, so 800 milligram is not needed. Just a 300 milligram SR dose of micronized progesterone is more than enough, unless again the lining, we also have to see the endometrial thickness in that case. So that if the endometrial thickness in that case is thin, if you feel on the day of ovulation it is still it is not triple layer. If it is less than 7 millimeter, I would like to add on estrogen along with that. I would like to add on estrogen along with progesterone 10 milligram TDS during luteal phase support, and then continue once the pregnancy is positive, clinical pregnancy is reached, that we continue it till at least 12 weeks of pregnancy. Both estrogen and progesterone.
Okay.
Yeah, and the other question is guide on the treatment protocol for raised sperm DNA fragmentation. That is 30. Okay. So again, treatment protocol, again, you have to again go ahead with the counseling first. Like you have to take the history of the patient, whether the patient is alcoholic, smoking alcohol, taking alcohol or smoking, whether the patient is diabetic or not. We have to rule out all these parameters because we have to simultaneously treat that. Antioxidant, see again, the age of the patient. Antioxidant per se, I cannot tell you the brand name, but there are a lot of combination therapies where you have to give, vitamin A, vitamin E, vitamin C, protodiazidine, astaxanthin. There are a lot of combination of drugs which we give at least for a period of 2 to 3 months. 3 months at least should be given. Usually we repeat the DFI after 2 months, see if there are any changes, and then continue with the treatment. So exact treatment protocol, again, that depends on the person, the age, and the sperm morphology and the motility of the patient. So if you are, I can share my contact detail if would like to discuss about one particular patient per se, Dr. Ashleisha. I'll be there to help you. Okay.
Thank you, ma'am. Thank you. Hello.
Yes, yes, ma'am. So,
I just want to grab opportunity to discuss with you, ma'am.
yes, ma'am. So,
First of all, I want to congratulate you for a very valuable information. And we all have received abundant guidance about infertility points and clarification about RIF.
thank you.
My question is about small uterus in POF, premature ovarian failure women.
Yes.
Say uterus is about a 4 by 3 by 2 centimeter. Then what are your strategies to grow this uterus or to treat this uterus prior of oocyte donation or directly for embryo donation?
See, for if the ultrasound, just if just the uterus is small, what we usually do is we at least give 3 months cycle. That depends what is the age of the patient, what is the size. Like you mentioned, it is 4 by 3 centimeters. So this patient will at least require not just 3 months, patient will require 4 to 6 months therapy of estrogen plus progesterone. So that is mainly for pre-treatment, mainly to increase the size of the uterus. After 3
So how
months of
you
treatment, estrogen,
so how you distribute that months means with of course you are using estradiol valproate for that, no?
Yes,
And
yes,
progesterone
yes.
combination. So how you distribute the months with these medicines?
So distribution of months is basically if you're talking about estradiol valerate. So
Yeah.
we're giving estradiol valerate, we are giving it 2 milligram per TDS, 2 milligram TDS for 21 days. And in the last 7 days, I'm giving progesterone that can be a micronized progesterone or a dydrogesterone. So so dydrogesterone, if we are giving, usually it is 10 milligram TDS for the last 7 days of the cycle. Then we stop. Wait for the periods. If the patient is in premature failure, sometimes we have to counsel that you might just, after stopping the medicine after 3 or 5 days, you might just have, spotting or
Spotting on
bleeding
the
for 1 or 2 days. If at all you do not have any spotting or bleeding, then after 5 days of after 7 days of stopping the therapy, again you can start with 21 days of E plus V, that is 21 days of estrogen, 2 milligram TDS, and last 7 days again progesterone. So 3 months we do that. We again call up after 3 months. We do a USG just to see the size before going ahead with oocyte donation. Again, here, if the FSH is not very high, if the FSH is still, more than 10 or less than 20, if the patient wants Along with hysteroscopy, we counsel the patient for ovarian PRP, that is ovarian rejuvenation. So we do hysteroscopy just to see the volume, because a 2D or a 3D ultrasound, we have increased the size of the uterus. We also need to do an office hysteroscopy to see the volume, whether it is receptive or not. And at the same time, PRP, if the patient is willing, because again, the cost factor comes that what is the success rate? Because for PRP, again, we have to give at least 2 to 3 sittings of PRP, which is hysteroscopic guided, which is ultrasound guided. So that depends. After 3 months, we evaluate whether that patient needs a 3 months or 6 months therapy, and then we go ahead with embryo transfer.
Okay.
Yeah.
And do you think that MT people will give rise to adenomyosis?
MTP pills, have you seen such case? I mean, there are not enough studies about MTP pills. If there are not studies, I'm not aware of the studies about that. So yeah.
Okay. So just if you will go across with this, then just note it down if you
Sure.
have any incidents of these things.
Sure,
Because
I
it
will
is
keep
my
that in mind.
observation.
I will keep that. It's a
Yeah,
very
it is
good
my
observation.
observation.
So you're talking about
Yeah.
just about the pills or curettage as well?
No, curettage per se will not increase the adenomyosis. Of course not,
Yes.
because we are treating that directly. But
Yes.
MTP pill, yes, and because of that, adenomyosis grows well, means more, and because of that, a recurrent loss is there or arrives there. Means implantation failure will be there. That is my observation. But I want to discuss this point with many gynecologists who just get the reply and their observation.
Okay.
And one more thing, that in advanced age also you prefer long protocol or you go with the short protocol?
That depends. That depends on the ovarian reserve. That depends on the AMH of the patient.
So do you prefer AMH versus AFC or how?
AFC.
Antral follicle count?
AFC, of course. So I do on my scans. I do, yes. I antral follicular count. Depending on that, I take a call. Depending on the age.
Because AMH is
So
really
in
not
such
valuable.
cases, what I usually do, like I don't use long protocol in a lot of cases, but in such cases, even with a diminished ovarian reserve, even if we add growth hormone for initial 5 days of treatment, I have seen increase in at least 1 or 2 good quality M2s in that. So I use growth hormone regularly in such patients, along with recombinant FSH and LH.
And one very important question actually, about embryo transfer, the site of the embryo transfer. What site you usually prefer for day 3 and blastocyst embryo transfer?
It actually doesn't matter. Like if you're talking about, if you're talking about the
1
distance
centimeter
from the
below the
fundus.
fundus.
So even in the studies, also even in the guidelines, whether it's 1 centimeter or 1.5, some do it at 2. It does not matter. It should not 1 centimeter. It is always, I always do my embryo transfers under ultrasound guidance. I've done my baseline scan. I have already taken the UCL, and depending on that, I do. So
all the transfer you prefer to do 1 centimeter below the fundus line. Yes, below the fundus, 1 centimeter. It is said, means some publications are there.
See, sometimes it is 1, sometimes it is 1.5. There are also, a lot of publications and studies where they say, you transfer where the endometrial thickness is more. But then again, that has not caused any significant, because I have in my practice also, because these are all my ongoing studies. So there also, I have, changed the location depending on the ultrasound, depending on, just 0.5 centimeter change in that. So yeah, I'll definitely
because
share.
While we are doing transfers in EV actually, so we used to transfer blastocyst 1.5 centimeter below the fundus, because it thinks that blastocyst does not move more in tube than day 3, because day 3 is to move. Okay. So here you practice this.
So then again, moving that depends on the amount of the media which is used. That depends on the precision again of the technique of the embryo transfer, how constant your pressure is on the piston. So it does not depend whether it's day 3 or a day 5 transfer, does not depend whether you do put it on a 1 centimeter or 1.5 centimeter below the fundus. If that pressure is not maintained, or while loading, lot of embryologists, that depends, like whether you're using a sandwich technique, if the amount of media is
Sandwich, yeah.
yeah, so if that depends on the amount of media also sometimes. So
Okay. And do you recommend breast? Do you recommend breast after embryo transfer? No.
No. Bed rest. See, rest again. There are two, very two different things. Of course, we just observe the patient for 15 minutes because we have done a procedure. Patient is lying down after 50, because sometimes she may have syncope or vasovagal attack. Just for that, we are just asking the patient to lie down for 20 minutes. After that, not bed rest, but yes, house arrest for 2 to 3 days, because they should be avoiding any physical, strenuous activity, or avoid but routine day-to-day activity has to be done unless there is some other complication, any other comorbidity. But
well, I don't recommend rest actually. I don't recommend rest because that is my publication in infertility sterility. That is bed rest is not have good impact. Yeah,
not
yeah.
recommended.
Okay.
In fact, it has a detrimental impact. Detrimental
Yeah,
effect.
that is a detrimental effect because of the position of the uterus in standing. Well, thank you very much. Very nice information. Thank you.
Thank you so much. And I'll get back to you about MTP, madam. So
yes, of course. Thank you.
Yes.
Okay. Thank you, Riju madam. You have explained every queries very nicely. Now we will go to vote of thanks.
Thank you so much, Dr. Vankare.
On behalf of NIMA OBGY Society Central and NIMA OBGY Society Maharashtra, I would like to express my sincere gratitude to NIMA Central President Dr. Ashutosh Kulkarni sir, Secretary Dr. U.S. Pandey sir for the remarkable support. I would further like to extend my gratitude to our NIMA OBGY Society Central President Dr. Kamini Dhiman ma'am, Secretary Dr. Priyanka Nakade ma'am, Treasurer Dr. Vishnu Bhavane sir, and Convener Dr. Rajesh Utane sir. I would like to thank NIMA OBGY Maharashtra President Dr. Suhas Herlikar sir, Secretary Dr. Manoj Gaikwad sir, and Treasurer Dr. Ajay Bal sir for their support. Above all, I would like to extend my sincere thanks to our eminent speaker, Dr. Riju Chimote madam, who took time from their busy schedule and gave us today's wonderful talk. I would also like to thank Dr. Girish DAGA sir and my coordinator, Dr. Brunali, for all the help and technical support. Last but not the least, I would like to thank from the bottom of my heart to all the delegates for their precious presence. Now, with the due permission of all the dignitary, I would like to conclude today's webinar. Thank you very much. Thank you, madam. The chat box is now flooding for the appreciations.
Thank you.
You have given very nicely, nice session
today.
Thank
you so much, and thank you so much all the delegates, all the consultants who logged in.
Thank you so much, Riju ma'am, for giving your precious time to us.
Thank you. Yes, of course, and thank you so much, Dr. Archana, for introducing me to NIMA OBGYN Society. It was a wonderful experience. So,
it was really a wonderful time with you, and it was a treat to hear you. Thank you so much, ma'am.
Thank you. Thank you.
Thank you everyone for joining. We can now end the meeting.